Hi, this is Dr. Robert Good. I'm the current Medical Director of Clinical Integrated Operations at Carle, and I'm the current co-chair of the Carle, Illinois College of Medicine's Curriculum Committee. And I'm speaking to you today from the lobby of the Carle South facility on Hurst Drive. Probably one of the finest facilities in all of Carle, the center of the patient-centered medical home, the future of healthcare, and the model that we are striving toward to improve patient outcomes and patient safety. And today we're going to talk about physician burnout. You know, physicians go through a lot of things in which sometimes they just simply hit the wall. They start school with an extremely vivid and passionate drive to become great physicians, and by the time they have finished their second semester of 29 hours of very concentrated, high-level medical school work, they start to not see the relevancy of what they're doing or the impact of how they're to be affected. They're not seeing patients, they're memorizing huge amounts of data, they're worried about passing part one of the boards, and they start to have this reversal of that passion and energy and mission that they had to begin with. Burnout is a syndrome of just emotional exhaustion, loss of meaning in work, and a feeling of ineffectiveness. And that begins to make a tendency to view people of something other than human beings. In America, about 45% of physicians meet the criteria for burnout, and I dare say that almost every physician has experienced burnout at some point in their career. A recent Mayo Clinic study demonstrated that this has increased even in the last 3 years. Last year, 154 physicians in training died of suicide or drug overdose. That's an entire medical school class. Why do physicians burn out at a higher rate? Well, one is the practice of medicine. There is a change that's occurring, and change itself creates problems with burnout. We lose some of our change capital, and it's not just that there's a change in the American healthcare system. There's a change in how we do things on a daily basis. Nurses change. Who's my usual nurse is no longer my usual nurse. I have different staff members, sometimes frequently and every day, who don't understand what my specific needs will be. The electronic medical record is increasingly complicated with increasing demands, and we have boxes we have to click, and it deters away from what we came here for, and that is patient care. There are administrative things that have to be done to meet certain criteria. The payment schedule is based upon our ability to create value. And in the middle of all of this, we now are throwing in transparency so that physicians' profiles will be published on our website, and that creates further stress, a feeling of lack of control, a feeling of lack of effectiveness, no matter how hard they try. And then there's all that other medical, non-medical stuff, the stuff that has to do with everyday living. There is stress in the home. Physicians are home. They're tired. The families want to see them. There's demands of the family. And sometimes they can't meet all those criteria. There's all the non-medical stuff that we have to do. There's paperwork to fill out. There's insurance forms to complete. There is time that takes a lot of time that is valued with no compensation that we have to do. And the medical education system does not prepare us for this. Residents are set up for burnout because of extremely long hours and a constant change of shifts. They have difficult decisions to make for the first time in their life, and they don't have a lot of experience. And so now they're making life and death decisions, and they're at risk for error. Death and dying is now occurring for the first time in their life. They've not really experienced death and dying before, and at least not to the level where they are in the driver's seat. They are separated from their families. No longer are they able to go home on weekends, or they're able to see their families and their support systems. They're removed from that, oftentimes for hours within the hospital while being on call. And then there is the educational system. the educational system that thrives or used to thrive on pimping, asking those difficult questions so that really nobody can answer. We develop all sorts of survival tools. We may become an excessive workaholic, where we're just present all the time. Or we become the superhero, where we think we can solve any problem at any time. Or we separate ourselves away and become the Lone Ranger. Or worse yet, we become emotion-free. We don't give a care type of attitude. And all of this is a result of emotional exhaustion and what we call compassionate fatigue. Something that just constantly erodes at the mind, the body, and the spirit. We have learned to run on empty. Medical students have depression rates at 15 to 30 times higher than the general population, and that is a major factor. And about the time that mid-20s come along is a time when bipolar disorders and alcohol and substance abuse start to thrive. And in the middle of a stressful situation, it starts to make a difference. So how are we going to change this in our new Carle University of Illinois Medical School, and how is the curriculum going to affect that? Well, number one, we are starting with a problem-based learning environment, and that is driven by relevant cases. We're encouraging physician leadership or student leadership during these processes where they work in teams and support each other. We're going to minimize tests, but we're going to emphasize competency. How is it that the student is progressing? We're going to de-emphasize step one test of the boards, and we're going to emphasize the need for continuous learning, that the problem-based learning process does a better job at preparing us for our lives. Most of the stuff that I learned in medical school that I consider to be facts 40 years ago really aren't facts. And so it's really how do we learn and how do we keep that? How do we prevent the students from being isolated from each other, working together in teams? The students will look at big data to analyze and predictive analysis and prepare for the population health of the future. And all of this innovation and research that comes through engineering and science should help maintain the passion for meaningful outcomes and the presence of cases, real cases, and the early integration of clinical contact, even in the first year, should increase the relevancy of what they're learning. We want to teach the students and residents how to become empowered EMR users so that they're not only just good at it, they're great at it. They understand how to use a computer, which most of them do already, and use it to efficiency so that medical notes have a continuity and are meaningful in what we're trying to achieve. We need to talk to students from day one to reduce guilt, to take a day off, to train the students, clear the deck. It's okay. It's okay to do that. We need to emphasize the need for healthcare teamwork and train leadership techniques. All of these things increase and keep us focused on the mission as to why we're here in the first place. We teach something called resiliency training. Only we teach people from the day one what it's like, what the emotional intelligence process is like. How do they get to know themselves in a better way when they know enough is enough and they can stop before they do hit the wall. Students, residents in the educational system, and those of us who are faculty need to acknowledge that there is a potential problem of depression and burnout, provide training for conflict resolution, teach them life skills that in the educational program. How do you support a family? That is very important as these students are growing up. They got young families, mainly newly married. They're adjusting to life in a much different way. As physicians, we need to reach out to the future physicians who will be our future colleagues and to each other when we identify that burnout may be occurring. And remember, it's not just physicians who are burnt out. We have a healthcare team that's feeling that as well. It's been reported that about 90% of nurses have episodes of burnout, but other healthcare staff feel much the same way. So I hope this helps you, give you some hope that the new Carle University of Illinois College of Medicine will develop a curriculum and a method to help students so that they don't experience burnout. It probably will occur, but the idea is that we can identify it early and that they can identify in each other. And by working together in teams and developing the self-leadership, they can maintain their purpose and passion for medicine, for research and innovation to carry us into the future. I hope this is helpful to you as a committee, and if I can be of any service or answer any questions at another time, I'd be glad to do so. Thank you.